Hello everyone, this is Dr. Shruti and my presentation is on iodinalysis repair, bridging the iris, precision repair and restored vision. So as we know, iodinalysis repair is a complex procedure and requires special instruments and good surgical expertise. So here we describe a simple suture technique to repair an iatrogenic iodinalysis that occurred during a small incision cataract surgery. It is a very simple technique and involves minimal tissue handling. So the aim was to provide a functional and a cosmetic result in the same sitting as a primary procedure with the common available instruments. The incidence of iodinalysis due to SICS stands at 0.2%. Intervention may not be required if the dialysis is small, but large and asymptomatic dialysis requires surgery. The superior iodinalysis involving 10 o'clock to 2 o'clock position are less symptomatic as it's covered by the upper eyelid, whereas the temporal, inferior and large iodinalysis are symptomatic. So numerous techniques have been described, most of them are being technically challenging. So here we describe a simplified approach of iodinalysis repair using 10-0 ethylon suture and basic instruments used for a conventional cataract surgery with a favorable outcome. So this slide depicts the pre-op image where this is a figure 1A which shows the pre-op photograph showing an inferior iodinalysis from 4 o'clock to 8 o'clock position and the prolapsed iris which is seen through the main wound. And figure 1B shows the pre-op photograph after depositing the iris from the main wound. And this is the post-op image where the iodinalysis is corrected and formation of fairly round pupil is noted centrally. So this is the schematic representation of the surgical technique. So as you can see, this is the pre-op photograph where the iris is prolapsed with sclerocorneal tunnel and iodinalysis is noted inferiorly. And after depositing the iris from the main section, an inferior conjunctival peritomy is done where the suture is passed from the sclera and taken into the corresponding iris inferiorly and the suture is exteriorized through the cornea. And suture knots are rotated into the angle of the anterior chamber to approximate the iris towards the insertion. We could not capture the intra-op video. This is a demonstration model where suture is passed from the sclera through the corresponding edges of the iris inferiorly. The suture is exteriorized through the cornea. The suture knots are tied individually in 3-2-2 fashion. So the advantages of this technique is it can be performed with available instruments used for conventional cataract surgery, and stability of the anterior chamber is also maintained and involves minimal tissue handling. However, the disadvantage is that the exteriorized suture on the cornea can cause irritation and pose a risk for infection. To address this, BCL application is advised and closely monitored, and the patient is put on topical antibiotic eye drops along with regular post-op medications. So to conclude, this is a simple suture technique which would come in handy in urgent situations and requires less expertise and minimal common surgical instruments. Thank you for giving me this opportunity.
Can you please explain when you suture the iris, will it not get anteriorly displaced and get stuck to the peripheral cornea if you are passing, and also a corneal astigmatism also might be there, I think. Conventionally, we pass the suture through the sclera with a flap and then tie the iris, whatever the part of the iris, to the sclera where it fixes into the sulcus. Now here you are taking it in the cornea, so your iris is getting pulled anteriorly. So are there any complications that you can think of that can arise in this?
We have employed this technique in 2 surgeries, ma'am. We haven't encountered any such complication post the procedure.
Another thing is you're putting a BCL, but you can't keep the BCL for a long time.
Yes, ma'am. After
So
trimming the suture, we'll remove the BCL, ma'am.
yeah, but the original technique where you actually approximate it to the angle is itself a very, you can just keep a 90 Prolene in the OT. So it's just a straight angle and you can take it. And that is not exteriorized, you know, so the risk of infection and irritation is much less. So in this case, even though you're using a 10-0 ethylone, but you're passing it through the cornea, peripheral anterior synechiae, exposure to outside. By taking a peritomy, you're not achieving much because anyways it is exposed on the corneal side. How much actually it's going to impact other than using a 10-0 ethylone instead of a 9-0 proline.
That's great.
Yeah.
Uh, we are just finishing in time. We have some recognition of the chairpersons. First, before your Shruti. Shruti, please. Good job.